Welcome to Concurrent number 14, COVID-19 Results in Innovations. My name is Mark Casselman, CEO of Digital Health Canada, co-host of eHealth 22. I trust you're all having an outstanding day learning, collaborating, and networking through the conference. This session includes two 15-minute oral presentations. If you have questions or comments for our speakers, please type them directly into the Zoom chat, and we'll address them as time allows. You're also encouraged to connect with the speakers directly after the session via the virtual event platform. I'd now like to welcome our first presenter to the virtual stage, Kelly Lane, Director of Operations and Projects, CDI Program at University Health Network. Kelly, welcome. This virtual stage is yours.
Great, thanks, Mark, and thanks everyone for having me today. Let me try and advance the slide. Here we go. So I'm here to chat with you about understanding and managing surgical backlog and what we've done at the University Health Network for that. So a bit about our organization, for those of you who are not familiar with UHN. We're comprised of 3 acute care hospitals, so Toronto Western, Princess Margaret, and Toronto General Hospital, as well as Toronto Rehab Hospital Institute, and Michener, which is an academic institute that's dedicated solely towards health science education. UHN has Canada's largest surgical program. So we have over 13 surgical divisions. We have 39 operating rooms and over 140 staff surgeons. And annually before the pandemic, we were conducting 25,000 operations. So huge operation within our organization, and our division is quite large. So what was the problem that landed on my doorstep? Our head of surgical oncology came to me and she said, we have no way currently to proactively manage our surgical wait times and our surgical backlog. The process was decentralized, so there was inconsistent processes happening across all of our surgical divisions. Some divisions were managing them centrally, others were individual surgeon offices managing their own wait lists and backlog. There was a lot of manual processes, which led to a lot of redundant and inconsistent data. And it really resulted in the need to add additional steps to reconcile the information across multiple systems. And then finally, there was a large data delay with all of our wait times and backlog. It was reported monthly, and we had no way to be able to proactively manage and adjust and pivot as quickly as needed. So this just gives you a sense of what our workflow was like just to book a surgery. This is one of our surgical services. It was actually one of our better and more efficient surgical services, and this is what it looked like. They were entering the same information in 5 different places, and it was estimated when we started this process that each surgical division was spending between $10,000 to $20,000 annually just to manage their wait times and their backlog of cases. So it was a huge amount of investment and time that was going into doing this. So what was our solution? Actually, we're not going to go there yet. We're going to talk about wait times first because I forgot about this slide. So for those not from Ontario, in Ontario, we publicly report wait times. So the wait time that I'm specifically going to be referring to throughout the presentation is surgical wait 2, which is the time from the decision to treat to the time the patient actually receives the surgical procedure. There's 4 priority levels, 1 to 4, and depending on if it's an oncology or a non-oncology procedure, there's different targets of waits for those procedures. So this became really important for the architecture of our system and understanding our clinical workflows, because many of our surgeons did both oncology and non-oncology procedures. And despite the original ask originating from our Department of Surgical Oncology, we wanted to be able to have a system to address both so that we didn't end up fragmenting the workflows depending on if the case was oncology or not. So the solution that we came up with was the Surgical Wait Information Management System, SWIMS. So when we started down this path, we found that our current hospital information system could not manage our surgical wait times, nor our surgical backlog. And we found that there was no product out in the ecosystem that could do it either, because our volumes were just too big and they couldn't handle our level of operations. Most of the products out there treated surgery as one service, where we actually have 13 different services within the one. So the advantage of being a technology and development department was we were able to build the solution ourselves, which allowed our organization to essentially manage and consistently track all of our wait times, priorities, and backlog across all of our surgical divisions. So what makes our system unique? It's really the management of surgical backlog is one of the components. Our system actually has no data entry. So we're able to leverage existing data within our ecosystem to produce all of the reports and tracking that's required for surgical backlog. We do automatic wait time calculations with comprehensive algorithms that take into account if the procedure is an oncology procedure or not. And we also take into account DARTs. So those are delays affecting readiness to treat. So if you offer the patient a procedure date and the patient says, I'd like to defer it 2 weeks, that time is then subtracted from the overall wait. And it aligns with how we report things currently to the ministry. As you can see in the screen capture, any patient or case that's waiting outside of the range or the recommended target is flagged red within the system. So we can visually keep track of who's waiting longer than anticipated or that we want. So in terms of our adoption, we've deployed SWIMS to all of our 13 surgical divisions. We have over 400 multidisciplinary users within our system, which includes our 140 surgeons. We facilitate the planning of over 37,000 surgeries and procedures annually. Since deploying to surgery, we've also deployed this to all of our endoscopy procedures as well within the organization. And we actively manage a backlog of over 3,000 cases at any point in time. In terms of usage, we easily have over 1,000 unique logins monthly. Often it's the same users going in multiple times, and we have the users generating over 500 reports to help support kind of their day-to-day flows within the organization. So in terms of the pandemic recovery, SWIMS became super important because it enabled us to contextualize how services were impacted by all the various waves of OR closures that occurred. So we were able to see like groups such as orthopedics were disproportionately impacted by all the closures because they weren't considered a life or limb service. So their wait times and their queue actually grew quite substantially. And you can see that the top line in the bar graph there. It also enabled us as an organization to accurately estimate the time and the resources that would be required to clear our surgical backlog, and provided us with the data to apply an ethical schedule to all of our OR resources. So for example, if we ended up getting allocation for extra OR time on a Saturday, how was that OR time assigned to all of the different services? In addition, because the system's real time, it really provided us with a mechanism to monitor and evaluate the impact of the strategies that were implemented for recovery and allowed us to pivot really quickly when needed. So you can see with the graph at the top with all of the closures and all the time, as things evolved as quickly as they did during the pandemic, we had the real-time data to know what we needed to do day to day and week to week. And then also importantly, from an administrative perspective, the system allowed us to have the data real time to advocate for additional funding and resources that we needed to support our patient population. One of the other unique aspects of SWIMS is we support a concept called surgical smoothing. And I'm not sure how many people are familiar with this, but it's a method for scheduling surgery and cases to minimize the variability and the flow associated with patients. So really what you want to do is avoid those kind of peaks and valleys that stress a hospital that is near capacity. It's a concept that was first introduced by Dr. Litvak and his colleagues at Harvard Medical School. And what they found is that during a hospital's busiest times, that 70% of all the diversions from the ICU were really associated with this variability in the scheduled caseload. So as the number of elective surgeries peaked, so did the number of patients that were diverted from the ICUs. So I've put the reference up there for those that are interested in reading more. But what we did was we collaborated with the Institute for Healthcare Optimization to really understand our variability as an organization and to help provide recommendations of how we can minimize those peaks and valleys. So some of the recommendations are things such as designating one or more ORs for urgent and emergency cases, so you're not bumping schedule cases, and then also using block scheduling for all of our surgical caseloads. But I just want to mention this is a journey. It involves change management. And SWIMS was just one of the tools, but it also involves a lot of policies and procedures to be able to support this concept. And in SWIMS, what you're able to do is then visualize this. So what happens is if you're getting close to your threshold of what your smoothing target is, the calendar will be reflected in red to let you know that you actually have more patients that are scheduled to be admitted onto unit than the number of beds that you have available. So it lets our clinical teams be able to proactively manage our current surgical caseloads, because we often have multiple services admitting to one unit. And what we're doing is trying to reduce that variability so that our teams are not scrambling to find patients or sending patients to inappropriate units in order to accommodate our volumes. All right, so how have we evolved since our initial implementation and through the pandemic? We've deployed our system to all of the surgical services. It's become our organizational source of truth for the backlog. We've implemented additional sub-priorities for all of our priority 3 level oncology procedures. Our organization tends to have the majority of cases in priority levels 3 or 4. And as our backlog grew into the thousands, it became very hard to differentiate between all your priority 3s of who needs to go first. So those additional priorities or sub-priority levels really helped us support better decision-making and patient advocacy of who are those patients that really need to have their procedures done. We've onboarded all of our endoscopy procedures and added our own endoscopy procedure levels. And we've also designed a heat map view to support our surgical smoothing. We didn't get a chance to fully implement it because our organization is currently in the process of transitioning to a new hospital information system. But again, this system did not have the features to be able to track and monitor wait times in our surgical backlog. So we had to work with them to take the functionality within SWIMS and build it within the hospital information system, which is set to go live this weekend. So it's exciting to see how that's being built out and how the system is evolving within the new system. So I will stop there because I want to make sure there's some time for questions. I know it was a lot of information, but thank you very much, everyone, for having me, and I hope you enjoy the rest of your conference.
Well, thanks very much, Kelly, for sharing your story of the SWIMS innovation work at UHN. Again, the opportunity for our attendees to add your questions and comments into the chat through the presentations here. And up next, we welcome Alexander Dahl and Baptiste Laget of Akinox Excellent. The microphone is yours. Welcome to our virtual podium.
Thanks, Mark. It was fantastic to see Kelly's presentation and hear about the work done at UHN. COVID has really highlighted so many aspects of the healthcare system that have been bursting at the seams, let's say, for a long time, but were really exacerbated during the pandemic. So we're going to talk to you about one of the implementations to help solve some of those issues and bring another tool to the toolbox of public health. Our presentation is titled Building the Apps That Beat TikTok, Facebook, and Instagram. It's a bit of a clickbait, but we'll get back to that. So we're a Canadian company nearing 100 colleagues working from within Canada and internationally, and seeking to help bring a technology platform that supports digital process automation within healthcare to help reduce the impact of efficiency and effectiveness of lacking resources and putting the patient at the center of care. Our platform was used for the pandemic response, for virtual care, for screening, early childhood disability diagnosis, and many clinical pathways across 65 specialties and subspecialties. But we're going to focus on the applications that we've built in the context of the pandemic response. we built a full ecosystem for certifying COVID-19 vaccination in Canada. And this is from issuance to holding and verification. We started way back when in March 2021, emitting proofs of vaccination certificates for the government of Quebec. And this was the first North American jurisdiction to adopt a digital proof of vaccination credential. This was before the Smart Health Card was an officially adopted standard. In the summer of 2021, then working with the other provinces, Canada recommended the adoption of the same standard that was demonstrated in Quebec to issue a proof of vaccination certificate using the Smart Health Card standard, which is based on open and interoperable notions, and that is seeks to be as privacy safeguarding as possible. There were other solutions looking for a problem, let's say, solutions with blockchain, hyperledgers, private links that individual provinces would issue, but that would not solve the piece of equity of access to give the information to the patient or to the population, that they would be able to have those credentials verified in other jurisdictions or internationally, which was the objective to do so, and to do so in a context where everything was an emergency, as you've known. In September 2021, the first mandated uses of the verifier applications were released for Quebec, and followed by Saskatchewan and Newfoundland in the fall, that have adopted the same sets of technology that we have provided. A little known fact is that as of October, our applications were the first ones to recognize foreign proofs of vaccination too. Unfortunately, there's not a single standard for verifiable credentials internationally, but our applications made the experience seamless for travelers to the Canadian provinces to be able to recognize EU DCC's standards within the same applications. So to date, we've issued more than 12 million proofs of vaccination certificates, and it's still required for travel. So I was a bit tongue-in-cheek with the title, but we did beat Facebook, TikTok, Instagram, and whatever the young ones use these days in September 2021 with the release of the app. Now you may say, yes, it's a mandated app, but in fact, the verification was mandated. That the wallet apps that holds the proofs, people could have produced a paper credentials, kept a PDF or a scan of their QR code on their phone, and they chose to use the wallet application. So ease of use and a practicality for people that had to present their proofs of for domestic use case and then for travel use cases was a critical part of this design. So it resulted in 12 apps managed on different platforms, and it turned out for the year to be the second most downloaded app on the Canadian app stores. Now, it's a little unusual for IT providers to be so exposed to media attention. As you can expect, this was not an easy subject to deal with at many levels. Their policy had to be involved, explanation of how the privacy is safeguarded, how you're not tracked when you're using these tools. So from going from lines of code to lines in the media, it's in a matter of hours. It's an unusual experience for IT providers, and this led us to really have highlighted some lessons that were applicable to this context of doing high volume, high velocity, public use of technology for bringing the information directly to the end users, to the patients. So the brains behind the technology, Baptiste, on the call with us, is going to share some of those key lessons that we think are applicable to anyone rolling out technology to patients or to the public.
I think we're lucky enough to see that this success changed completely our perception of how we build products and apps and how we roll them out. And we learned a lot. And the first thing we learned is that when we claim we're building something that's designed to be private, when we use privacy by design, we cannot just stick to the buzzword. We decided very early on that the applications should be offline first, that you can use your app whether you have internet or not. We knew we needed to work without analytics, which is really hard to go back to your stakeholders and just tell them, we don't know what's happening with our apps, but yet we had to do this every Monday morning. This led to educating the stakeholders, but also embracing public scrutiny. You saw a few articles, and we took some hits. We had some wins, but it was definitely interesting to see this moving. A bugless experience doesn't exist. We will encounter bugs whenever we publish software. Users will live through bugs. The only issue is when you have more than 10 million users, 1% of bugs is a lot of support calls to support hotlines. We need to iterate carefully while remembering that we're in a pandemic, and we also need to iterate fast. We need to educate users around the concept of updates and how can we force updates to a system that's not supposed to be offline. We need to facilitate rollback. More than once, we started rolling something out in the nature and then realized it was incompatible with a lot of phones out there. And the offline apps are hard to fix. For a website, you can just push an update. For an app, you need to push it to all the devices individually. When users have to use the service, user experience is key. Nobody's going to read the manual. Nobody's going to read the help center. Nobody's going to look at anything. They want to use it right off the bat. So we need to change the way we design health software. We need to drop acronyms or technical terms that user will not understand. We have to work with accessibility. It might seem hard to do when, for visually impaired users, to scan a QR code is a challenge, but we had to think and devise something around this. And we need to make sure that however the user think they can get to the result, they will get to the result. So design a few ways around a problem to get to the same result. And during a crisis, we still have to care. We cannot leave anybody on the side of the road, especially if it's mandated. Every issue matters, and I think I can't count the number of late night calls that we've had to solve the problem, or of one or two citizens in the province. Iterating fast is not an excuse to exclude certain users, and we need to care during the whole process. And those are a few of the lessons that we learned on the way.
Thanks so much. Our time is limited. We could expand for probably write a book at this stage on a lot of these, and integrating everybody. That also means a proper offline first experience, paper-based solutions for people who are not at ease with technology, who don't have smartphones even. Accessibility was a key consideration, and the design occurred with people who have disabilities to ensure that it was that most contexts could be adequately supported by the applications. So what's next? This I think highlighted really the appetite for patients to be sovereign in their care, in access to their own information. I would say sunlight is the best detergent. Being able to give everybody their verified credentials highlighted mistakes that were done in binding the identity, in the wrong date or the wrong dosage. So being able to have immediate access to one's own clinical information, I think, is going to be the next step, and doing it in a way that supports a holistic continuity of care across the silos that we find in healthcare, not only within a province or jurisdiction, but also internationally. So interoperability, we have to go beyond standards. We have to really look at the user experience, the context, the consent, the flow of data, and how do we allow individuals to really maintain their ownership of their own data and decide who they get to share it with. So associating their digital identity, the know your customer aspect of all of this, how do you get the levels of assurance that you can say, I can share this data, this information about my parents because they're elderly and I care for them, but to what degree and with whom? And to really support an experience that goes internationally. So give control of their data across borders. all levels of borders, again, whether they're institutional or of language or internationally, to really be patient-centered at the end of the day. These apps for some of the provinces were the first mobile apps ever published by the healthcare ministry. So and this was 2021, there's a lot of catching up to do, I think, and in bringing technology to bear to help put a patient experience at the center of care. Maybe I'll end noting that the Vaccine Credentials Initiative, with whom we've collaborated, founded in the Mitre Corporation and involving lots of public and private sector partners to hone in around the principles of sharing verifiable credentials for data, was renamed from Vaccine Credentials Initiative to now Verifiable Clinical Information. So we're experimenting with how those standards have come to play in an emergency context in COVID, to be able to give people vaccine credentials for all of their types of vaccines and help certify them for schools without sharing unnecessary clinical information. Likewise, the International Patient Summary, how we could have smart health links that would allow you to have verified, certified information that you can share across the borders. And we invite everyone on this call who's interested in this subject to reach out to us and to look for collaborations to help make this happen. So thank you, and I hope you're all enjoying your conference.
Well, thank you, Alex, Baptiste, for that interesting look at building apps amidst a pandemic. Tremendous work. You know, I've got a couple of questions. I think we'll have time for one to start with, to both of you as well as to Kelly, before we break to move on to the trade show. And you both touched on this topic, which I think is critically important. We've seen over the last 18 months or 2 years is the pace of transformation has picked up, I mean, obviously across the board. And you both talked about, you know, enabling that through clear and tight communications between the technology leadership and the business leadership, both internally as well as in sort of multiple client contexts. If there was one or two key rules, I know you've shared some key messages with us, but just in terms of, you know, enhancing the pace of change with tight communication and clear communication between technology leadership and business leadership, what would you leave our attendees with in terms of advice? We'll start with you, Alex and Baptiste, and then I'll go to you, Kelly.
That's a great question. Definitely a lot of red tape has been eliminated due to the context, the emergency context. That was a breath of fresh air. And I think we can leverage the methodologies, the agile methodologies, working in true partnership, having innovation procurement rather than laborious, long waterfall designs of what an institution or a government may think they need, that 3 years later ends up in a solution that doesn't fit well. So having that intimate collaboration, that capacity to bring everyone in the ecosystem, patient partners, clinicians, IT providers, to innovate. I think governments should really focus on the infrastructure, setting the size of the tubes for the sewers and ensuring that consent and data sharing are all well taken into account, that the rules of the game are clear to everyone, that there's open interoperability, but that the collaboration should really be fostered at all levels so that we go towards innovation in a collaborative manner.
So I guess I could take it from my perspective, because I just focused on internal, although our organization, we have tons of red tape and things to get through as well. I think for me, your point, Alex, with bringing everybody to the table, the original ask for what SWIMS was very different than what we ended up deploying, because we were able to understand the business and understood the need was a bit more than what the actual ask was for. And the original ask was so limited because we tend to sometimes think small and trying to get things out the door quickly, that we end up creating more fragmented workflows. So really thinking holistically of what that would look like and how do we actually cut work out, because often we're adding but we're never taking anything away. And that was one of the big communications pieces for us, is we actually took a lot of steps, a lot of hassle out of the way. And there was actually no data entry. So I don't think I ever had anyone say, no, I don't want to use your system, it's going to be more work. They immediately saw the benefit. So it's not just a matter of being additive, but understanding the whole workflow and what can we potentially take away or streamline as well, since we tend to do things fragmented in healthcare.
Well, thank you, Kelly. Thank you, Baptiste. Thank you, Alex, for bringing your insights and thought leadership here to us at eHealth 2022. Next up, I'd like to invite all attendees to join our exhibitors for networking, discussions, and collaborating in the virtual trade show. You can access this at the top of your screen. I'll see you there. Have a great afternoon.